Hello, dear students. Welcome to the second part of a study on the reproductive system. Yes, we've completed anatomy and physiology of the reproductive system. We've also completed embryology of the fetus or the embryo and the placenta. Now we want to tackle infertility. Yes, infertility studies, or how to solve infertility problems. And with this, we are going to know when a woman is not ovulating, what are the things that we need to do. Yes, the laboratory has to do some investigations. Likewise, the sonographer or the radiologist have to also come in with ultrasonography and also X-ray, all in a bid to unravel the cause of either the primary or secondary infertility. Yes, by this, clinicians will now come in based upon the history of the couple, and also based upon laboratory investigations and radiological or biophysical testings. They'll be able to unravel the actual cause of the infertility of the couples and to mediate it or remedy it with appropriate interventions. After this lecture, we'll tackle our last lecture, which will be on in vitro fertilization, intrauterine inseminations, and also intracytoplasmic injection, also called ICSI. So we'll be doing intrauterine insemination, that is IUI. We'll also do IVF, which is what? In vitro fertilization, which is IVF. Then we'll end with intracytoplasmic injection, which is also called ICSI. So by this lecture is going to focus on ways of reducing infertility. Yes, so naturally we want the couple to deliver. But if the couple are not able to deliver naturally, then we'll come in with the next lecture as to how to create test tube babies. So laboratorians, in the embryology lab, laboratory staff manage or man embryology lab. So the in vitro fertilizations, the intracytoplasmic injections, the IUI or intrauterine inseminations, all these are done by medical doctors and also laboratorians, including radiologists and what have you. So we have to have an in-depth knowledge. This lecture, like I said, will focus on natural ways of remedying infertility issues. Then the next lecture will focus on how to create test tube babies. Please stay tuned as we zero in on this lecture, so that after this lecture and the following one, you will be able to advise patients as to whether their infertility problem can be resolved through the natural cause, or they have to go for artificial remedies, also called assisted reproductive techniques. Thank you. Let's go to the classroom now. Infertility. How do we work it out? Okay, so infertility is the inability of a couple to obtain a clinically recognizable pregnancy after 12 months of regular, unprotected, satisfactory, and adequate sexual intercourse. Meaning that if couples have been together for a period of a year and they have had unprotected sex, very satisfactory and adequate, there is no way they shouldn't have they shouldn't conceive. But if they otherwise set in, they are not able to conceive, then they should see a medical officer for them to advise them appropriately. So other definitions are: fertility of a couple is the sum of the fertility of the two partners. So we don't say that a woman is the only one supposed to be fertile. A man also has to be fertile. But if you're a man and you are not producing adequate sperms, or your sperms are of low quality, you cannot impregnate a healthy, normal woman. Fecundity, that's the probability of conception in any one menstrual cycle. So if you're a woman, your probability or your ability to conceive or become pregnant in any one menstrual cycle is called fecundity. Infecundity is the inability of a couple to achieve a live birth after 12 months of regular unprotected intercourse. So that's directly opposite to this one and also infertility definition. Meaning that you've stayed with your wife or your husband for one full year. We have had unprotected, satisfactory and adequate sexual intercourse, but still there is nothing to show for. No pregnancy is surfacing. Then you should know that you are in fecundity or you are infertile. So there are two types of infertility. There is the primary infertility and the secondary infertility. For primary infertility, it is defined as a couple who have never conceived in the past but have had regular unprotected intercourse for 12 months. So it's just defining infertility. For secondary infertility, it borders on a couple who have had a baby before, so you are born one, born two, or have previously succeeded in achieving at least one pregnancy, irrespective of the outcome of the pregnancy, whether the pregnancy ended up in stillbirth, abortion, or ectopic gestation. Whatever the pregnancy is, you have been pregnant before, and that is what is important. And that classifies you as a secondary infertile couple. And this one should have traveled within 12 months of unprotected sex. This is also sometimes called subfertility, or secondary infertility. So let's look at how infertility occurs. That is epidemiology of infertility. Approximately 10 to 15% of couples are affected by infertility. For a young couple with no adverse factors, the chance of conception per cycle per couple is around 20%. 60% of healthy women up to the age of 25 years conceive after 6 months of unprotected sex, whereas 85% conceive after 12 months. The single most important factor in determining fertility is the age of the female, because fertility is halved if the female partner is of an advanced maternal age. That is, if the female partner is aged. That's if she is above 35 years, then the fertility is 50%. And this 50% declines sharply after the age of 37 years. Meaning that women in this class try to give birth early, because after 35 years onwards, your fertility declines. You are not like a man who even at the age of 70 years he can give birth. He can just impregnate a woman. 65 years, 70 years, they can. 80 years before it starts, infertility starts to go down. And you saw this in our physiology lecture. So woman, by 35 years, your fertility is going down. Your antral follicles will be declining. Your antral follicular counts, your follicles that stores and release the eggs will decline. So your antral follicular counts will decline. So your follicular count will be going down. it will be going down. That is when you are aging. So you have to be careful. Give birth early. By 20 years and onwards, you start making advances and giving birth. Because after 35 years, sorry for you. Clinical evaluation of the infertile woman. So for you to be able to help an infertile woman to be able to give birth, the doctor, this is the position of the doctor, and is remedied or helped by the lab and also the radiologist. The doctor will take the history of the infertile woman. First and foremost, how old is the woman? How long have the couple been married? Duration of the infertility. Does the husband have a child somewhere? And if yes, then the number and ages of the children. Has there been any previous infertility investigations? Where did it happen? When and what was the result? Has there been any recent change in body weight? So if the person is losing weight, you'll be sure that if the woman is losing weight and you don't know the underlying cause of it, then you have to be worried because it can affect her fertility. Is there a history of hirsutism? Hirsutism is a genetic or congenital factor or anomaly, which is as a result of a woman growing a lot of hairs on her body, on her beard and others, even like a man or even more than a man. So does she have this condition? Because if she has this hirsutism, then obviously she will encounter an ovulation because she will encounter an ovulation, or she will not ovulate because she has a lot of androgen or male hormones, or also called androgens. So you have to also look at whether is she menstruating, and amenorrhea is as a result of a woman. Amenorrhea, when we say somebody is having amenorrhea, it means that the person has is discharging breast milk, whilst it can be a young girl who has not even been pregnant, and milk is coming out of her breast milk. Hello class. So I was at amenorrhea. Sorry, amenorrhea means that absence of menstruation. If you have absence of menstruation, you are having amenorrhea. So is the absence of menstruation in a woman who is infertile, is it associated with breast milk coming out of the nipples? That is galactorrhea. And galactorrhea can be as a result of tumors of the pituitary gland, and that do not spread beyond the scalp. And this may be associated with vision disorder or irregular menses. So most of the time, if breast milk is coming, because prolactin, when you are giving breast milk, women who deliver are new. Women who deliver freshly, when they are giving breast milk, they can have unprotected sex, and they will never become pregnant because the high levels of prolactin will suppress follicle stimulating hormone and luteinizing hormone levels. So if you are giving breast milk, exclusive breast milk for 6 months, and it is regular, there is no way that your husband can impregnate you. But if you stop the breastfeeding, your husband can impregnate you so fast. So is there a history of hirsutism, that's abnormal growth of hair of the woman due to male hormones or androgens, or amenorrhea, that's absence of menstruation, which is associated with or without breast milk coming out of the nipple, that is what's called galactorrhea. Coital history or sexual history. How often does the couple engage in sexual intercourse in a week? Is there adequate libido, that's the sexual drive, or any dyspareunia. Is there adequate libido or any dyspareunia? You are saying you are having sex. The dyspareunia means what? Pains. When you are having dyspareunia, it means that you are having painful sex. So dyspareunia is the persistent or recurrent genital pain that occurs just before or during or after sexual intercourse. Some of the dyspareunias are also accompanied with blood discharge or bloody discharge. You see that the person, blood will be coming out. The man's penis will be wet in blood, or the man's penis will you see blood on the man's penis. You see that the woman is bleeding because of the pains that she is having. And most of the time, it has to do with vaginal dryness. If the vagina is so dry, there will be friction and blood vessels will break at the cervix, at the vagina, and you see that there will be pains. So, is there adequate libido? If the women who don't have adequate libido, they tend to have vaginal dryness. Their vagina is very dry because they are not able to produce enough estrogen and those things. So their vagina is so dry and it's accompanied by pains. They have pains and friction during sex. So they tend to even bleed during sex. Does intercourse take place in mid-cycle or ovulation? Is the intercourse, do you have intercourse? Because if you have traveled, you are in Kumasi, your wife is in Bogatanga. How frequent do you people meet to have sex? When you are having the sex, does it fall within the mid-cycle or the 14 days after the first day of menstruation? That's when you start menstruating. Day 1 to day 14. 14, if a woman is having 28 days for normal menstrual cycle, and you start sex at day 8, you start menstruating at day 1. Do you have sex around maybe from day 12 to day 15? So the sex, you get it on the average on the 14th day. But you know that the 14th day is when you have the ovulation, and this is for those with the normal menstrual cycle of 28 days. Because when you have it around the ovulation period, you realize that there will be a high probability of conception or the woman becoming pregnant because she ovulated and the sperm, there were sperms there to fertilize the egg. So gynecological history, you finish with the history and the normal history and the coital history. Let's look at gynecological history of the woman. Menarche is the first menstruation or the first irregular, the first menstruation in a woman. At first it becomes irregular. So how long did it take for the menstruation to become regularized? The menstrual cycle length, duration of flow, and quantity of flow. So if your menstrual cycle is above 35 days, then that means that it's irregular because it's supposed to be 28 days or even up to 32, 33, 35. But if it's more than 35, it's around 40 and others, you should see that there is an underlying pathology or disease. Dysmenorrhea. Okay, so dysmenorrhea. Do you have dysmenorrhea? So it's also very, very important. Do you have dysmenorrhea? So do you have dysmenorrhea? And dysmenorrhea is painful menstrual cycle or painful menstruation. Do you have ovulation? That's mid-cycle pain. That's when you are having your ovulation. Do you have pains? Have you been using contraceptives like Lydia and Prostinol 2? They are emergency contraceptives and they tend to cause imbalance in estrogen, progesterone levels or hormonal levels. Even follicle stimulating hormone, luteinizing hormone, their levels can also can be their levels can be affected. You have vaginal discharge. What's the quantity of the discharge? Does it smell so bad? What's the color? Is there sore around or the vagina where the discharge is coming from? Is there sore around it, and is it itching? We also look at obstetric, or obstetrics is pregnancy. So pregnancy history. Parity means deliveries and abortions in the past. Number of deliveries, that's the number of children you have, whether live or aborted. Were there any complications of the pregnancy during labor, delivery, and 6 weeks post-delivery, or per period means postpartum or post-delivery, postpartum or post-delivery is the same as per period. That is 6 weeks, the period of 6 weeks after delivery. The period of 6 weeks after delivery. That is what they call per period. A period of 6 weeks after delivery. That is what they call per period. So the per period. Were there any complications of pregnancy during labor, during delivery, and also after delivery? With the abortions, were there any spontaneous? Were the abortions spontaneous or induced? The abortions that the woman had, was it spontaneous or it was an induced one or forced one? Was there any evacuation of the uterus? If the abortion was induced or forced, where was it done and what complications were associated with the abortion? Was the abortion painful? Did the woman have excessive bleeding? Did she have vaginal discharge? We also look at medical or surgical history. So, were there any history of serious illness such as tuberculosis, sickle cell disease, uncontrolled diabetes? Has any surgery been done on her before? So tuberculosis can affect fertility. Sickle cell disease can also. Uncontrolled diabetes can also affect. So tuberculosis, sickle cell disease, uncontrolled diabetes. The diabetes should be controlled. Hypertension should also be controlled. So if you have tuberculosis, sickle cell disease, and your blood sugar level is so high, or your blood pressure level is so high, they all affect fertility. And if you have had surgery, if the woman has had surgery done on her before, it also affects this pelvic surgery on the organs. Maybe they've cut your fallopian tubes and they are not there, and you are expecting a child. How can you expect a child if you don't have fallopian tubes? You have ovaries. Then look at the drug history. Any previous hormonal therapy? So have you been on hormones before? Have they given you estrogen, progesterone before? This will cause imbalance in the normal, natural estrogen level, follicle stimulating hormone level, and those things. So if you have been given any artificial hormonal therapy, you have to report to the doctor because it can cause imbalance in your natural, normal hormonal system. Drugs which tend to alter hypothalamic functions such as phenothiazines and metoclopramide. These are all drugs which affect the functions of the hypothalamus. So if hypothalamus function is affected, it will not be able to produce gonadotropin releasing hormones which act on the pituitary, anterior pituitary, to release follicle stimulating hormone and luteinizing hormones. So you should know that if you are taking these drugs, you are at you are at an increased rate or increased likelihood of being infertile. Okay, the social history. General stress from work. The men, you come from work and you are always tired. Woman, you come from work and you are so tired. If your husband even sleep with you to get nowhere, because you are tired, your fat metabolism is affected, your glucose metabolism is affected, your sperms will die, your sperms will not get strength to swim. Women, your ovulation or your ability to produce eggs will not be there because you are stressed out. Excessive alcohol and drug addiction also causes infertility. Physical examination. So for physical examination, we look at your anthropometrics. That's your height, your weight, which will lead to BMI calculation. And your BMI, if it is less than 16 kilogram per meter square, that means you are too thin, you are underweight, it affects your fertility. If you are overweight or obese, you are likely to have menstrual irregularities. You also look for the doctor will also look for evidence of chronic diseases, that is anemia. If your blood level is so low and you also have weight loss due to diabetes or anything, it will affect your fertility, because sperm and others, ovary and those things, they don't like high blood sugar and those things. Your neck, the doctor has to examine your neck and see whether there are thyroid masses or whether your neck has a web, like the duck, the feet of a duck. You know, the toes of a duck are webbed. So we have webbed neck also. Human beings have webbed neck. Is there hirsutism? And how is your hair distribution? Is there too much hair? Hirsutism means too much hair, and which is genetic abnormality. And how is your hair distribution like? We also examine the breast for masses and discharge. So is there any milk coming out of the breast whilst you are not pregnant, or you haven't delivered, or you are not breastfeeding? Why should milk come out of your breast? That means you have a pituitary tumor or something. We also examine your abdomen for surgical scars, that is scars. If you are having some scars on your abdomen, scars or scarifications. Do you have masses? If you have fibroid, it will affect your fertility. If you have ovarian tumors, that's benign tumors of the ovaries, your ovary is supposed to produce eggs. If it has tumors, it cannot produce the eggs. So you have anovulation. You are going to have what? Inability to produce ovaries. So you are going to have anovulation. Anovulation. Okay, your genitalia, your vulva, especially when we examine your clitoris. So the doctor will also do bimanual examination. That's, he will put two fingers, the index finger and the middle finger, into your vagina. But before he does that, he has to do something we call speculum examination. Speculum examination. He will open the vagina, he will open the vulva, hey God, my spelling is not good. Speculum, so the doctor will do speculum examination. He will use something like something to open up, speculum to open up the vulva. And this one will open up the vagina so that he can see inside and see the cervix, whether the cervix is having any bleeding, discharges and other things. Then you do digital bimanual examination. Digital bimanual manual examination. The doctor also do digital by manual examination. Digital by manual examination. Put his index finger and the ring finger in the woman's vagina to investigate whether the woman has what? The clitoris is big, that's masculine, very, very big clitoris. What are you doing with big clitoris? A woman. Clitoris is not a penis, so it's a penis in a woman, but the woman's own is so small outside but big inside. But here the clitoris becomes big like a penis, which is not good. State of the hymen. Is the hymen imperfect? Is the hymen of the woman, is there no hole inside the hymen? If there is no hole inside the hymen, then she cannot even menstruate, because where will the blood pass and come out? She can urinate through the urethra, alright, but she cannot menstruate. Is there any vaginal discharge? So by the speculum examination, you can be able to see all this. Presence or absence of uterus. Is the woman having a uterus or not? If she has a uterus, what's the size, consistency, position, and mobility? Guys, if you are going to marry, you have to be careful whether the woman, you have to find out to, like, you send your wife, your prospective wife, to a friend gynecologist or doctor, or you should go and do scan, deceive her and go and do scan for her and find out whether her uterus is there or not. Okay, adnexal tumors, meaning that tumors or lesions around the fallopian tube. Does she have lesions around the fallopian tube? Is a fallopian tube, are the fallopian tubes blocked or patent? The woman's fallopian tubes, are they blocked or are they patent? Is she having patent? Patent means that there is a hole inside that things can move inside. There is a hole inside the fallopian tube, so that substances can. So is there a pathway through the fallopian tube, or is it blocked? Is the fallopian tube blocked or is patent? Patent means that it's not blocked. Okay, so you can see all this. Okay, sexual history or coital history. Onset of puberty. When did the woman and the man have their puberty? Do they have sexual intercourse often or frequently? And is the sexual intercourse so sweet? Is the woman and the man potent? Does the man erect and ejaculate as he's supposed to? So the doctor has to assess all this history. Okay, so let's look at the infertile man, the history. So the same as the woman, you look at the age, his occupation is very, very important, because long distance drivers or trekking officers may be absent from home at the right time. When the woman is ovulating, they will not be there because they always go on long distance journey. When they even come, they are tired, they are stressed, and they can't do anything. So they will even miss the ovulation period. And also when they even get the ovulation period, the woman in the ovulation period, they are stressed that they can't perform anything. They can't produce good sperms. Okay, so the occupation too is the man a cook. If the man is a cook, you know the heat from the fire will affect testicular function, because the testicles will be atrophied. Because you know sperm does not like heat, as we saw it in our physiology lecture. Sperm is produced at the temperature of 34 degrees C to 35 degrees C. So if you are a cook or you are in the mining sector, you are always by heat, you should know that it will affect your sperm production. Then those who wear nylon panties, the way they are, they absorb a lot of heat, so it will affect sperm production. And how long have the man been married to the woman? And how long has the infertility been? Any previous marriage, or has there been any children outside the current marriage? Has the man suffered in the past from mumps? Mumps is a viral infection. Most of the time, the 6 childhood killer diseases the vaccine they use, they vaccinate against mumps. Because if somebody gets mumps, that's a high likelihood of causing the person to be infertile or have low sperm counts. Orchitis is also an inflammation of one or both testicles, and this is caused by bacteria or viral agents. So the viral agent can be mumps, and the bacterial agents can be normal STIs. The STIs, they cause yes, I'll finish right now. They cause orchitis. Any history of testicular injury? Has there been any history of the man being injured, the testicles being injured? Or have they removed the testicles, or have they done a hernia repair on the man, or varicocele repair? Varicocele is the varicose veins of the man. You know, the papilliform plexus that I showed you. When the venous drainage that goes to the inferior vena cava, when it becomes dilated, you know, the venous return will be very low, and blood cannot go back to the inferior vena cava and into the heart for circulation, or for it to be pumped again to get oxygenated blood. So we do varicocele repair to cause a constriction of the veins of the testicular veins. So if the doctor did not do it well, it will affect your sperm production. Any history of STIs or gonorrhea can also affect sperm production. Drug history. Recreational drugs such as alcohol and marijuana affect spermatogenesis. Prescription drugs such as furantoins and nitrofurantoin is an antibiotic used to treat and prevent urinary tract infections such as cystitis. Okay, so nitrofurantoin, nitrofurantoin. So, like I said, nitrofurantoin, furantoin. So nitrofurantoins, these are drugs. Nitrofurantoins. These are drugs that are used to treat urinary tract infections or UTIs. Urinary tract infections or UTIs. Urinary tract infections. They can also be used to treat cystitis. And cystitis is infections of the urinary bladder. Urinary bladder infections is called, or an inflamed urinary bladder is called cystitis. So what we do is that we examine so nitrofurantoins are antibiotic for treating urinary tract infection and cystitis. Calcium channel blockers are antihypertensive drugs. Example is nifedipine. They may affect sperm production or function. So if you are hypertensive, a man, and you are hypertensive, and you are taking nifedipine, which is a calcium channel blocker, it will affect your sperm production. You have to change the drug. Maybe you can change the drug to, you can use any other like lisinopril and the rest. You can use them instead of using the calcium channel blocker and nifedipine. But this does not mean that all calcium channel blockers are not good. It's just the nifedipine that is associated with these adverse effects. Physical examination. So you find the general state of the health of the patient or the client. Find out the degree of androgenicity, hair distribution. Is he really a man? Is he producing androgens or male hormones? His hair distribution, his voice. When some men, their voice is like a woman's voice. So some of them, with a woman's voice, do you think you will produce normal sperms? No. Genital tract. So you evaluate the size of the penis and the urethral opening. So, for instance, if the penis is so small, how would it be possible for it to even produce quality sperms? Then we examine the penis and see whether it has hypospadia, epispadia, or normospadia. Is there any discharge coming out of the penis? So if the person is not able to shoot straight, but it shoots up, this is the urethra, and it's attached to the back of the penis, then the sperm will shoot up, so it cannot enter the vagina. It will just shoot up and enter somewhere else. We call it epispadia. But if it is shooting down and it's not getting to the target, the vagina, we call it hypospadia. And if it is the urethra is through the glans penis, the pupils is through the glans penis, we call it normospadia or normal. So you have to examine if a baby boy has the urethra not going through the glans, then there should be a surgical repair. You can see this is the urethra. Here too, the urethra is under. So a surgeon has to correct this abnormality by putting the urethra inside the glans space. Okay, so in Oconfanotis, semen analysis is usually done first, and if there is any abnormal findings, a thorough physical examination is subsequently carried out on the man.